right now. Okay, Alice.
Okay, so well, that's still echoing. Anyway, good morning. Today I'm going to talk about serious mental illness and addiction, mostly through clinical vignettes. Many of these vignettes come from my book. You can put yourself on mute, I think.
I am on.
Oh, sorry.
I'll
We're getting,
I'll go elsewhere.
okay, sorry. We're trying to rearrange ourselves so we don't get an echo. Uh, Many of these vignettes come from my book, so please forgive me if you've already heard them. I'm reading this, so please let me know if I'm going too fast. I'll talk also about fee for service, that is, insurance based systems, versus single payer, no insurance systems, and their effects on patient care as well as cost. If you have questions or comments, please ask them as we go along. I think for this topic, it'll work better than saving them for the end. So, I began my psychiatry residency at Chope Hospital in San Mateo. For the first 6 months, we residents covered the ER. Some patients came in voluntarily, but others were brought in by the police on a 5150. The 5150 is a 3-day involuntary hold for patients who are a danger to self, danger to others, or gravely disabled due to a mental illness. With patients on a 5150, our job was first to evaluate them and decide if the 5150 was justified. If we thought it was, we would write our own 5150, documenting all the reasons for that decision. If we thought it wasn't, we would we would document all our reasons for that decision, hoping it was right. The ER had a nurse's station, a waiting room, and a small office where we met with patients. Across the hall from the little office was the locked room, a long, narrow room with a bed at the far end, bolted to the floor. The bed was furnished with restraints, leather straps that held the patient to the bed, two for ankles and two for wrists. It was kind of shocking. The patient in restraints was always a man. I'd go in quietly. I always thought it was an advantage to be a woman. The patient is still the only man in the room. If I could get any sort of conversation going, I'd ask him if we could continue our conversation across the hall in my office. Nobody ever refused. Then I'd unbuckle the restraints and we'd go across the hall and talk. Residents differed on whether to close the door or leave it open. I always closed it for privacy. One night, I was sitting in the interview room when a new patient came in, strapped to a gurney, brought by the police and an ambulance crew. As he passed by my open door, he looked over at me. He reminded me of Rasputin, tall, black hair, a pale face, and a casual look I couldn't read. As they came out of the locked room, both the ambulance driver and the cops called out to me, "Head injury." On the face sheet, they called him the vampire killer, hunting vampires with a lead pipe, they wrote. I pictured a struggle and the cops hitting him on the head with a billy club. In medical school, we were warned about head injuries through the story of a schoolboy who was hit by a baseball. He refused ER care and went to bed, missed dinner. In the morning, his mother found him dead. The boy's skull was cracked. A large artery was cut in the sharp edge of the bone, and blood poured into the space between his skull and his brain. Finally, it forced his brainstem down toward the foramen magnum, that big hole in the bottom of the skull. Then the cranial nerves were crushed, first those innervating the eyes, and finally the vagus nerve, which serves the diaphragm. At that point, the boy stopped breathing. To prevent this, you check the patient's eyes periodically, which will show the first sign of trouble. When I went into the locked room, Mr. Walker, the vampire hunter, watched me calmly, but he wouldn't talk. I took my pen light and he followed the light as I asked, but was silent. He had a perfectly normal exam, except for a large lump over one ear. I came back in an hour and he was the same. Follow the light, pupils equal and reactive, but wouldn't speak. I waited for 2 hours this time and came down to the ER at 3 a.m. It felt spooky. The lights were low and I was alone. His exam was the same, and I asked him again if he could talk to me. This time he moved his lips as if he was trying to talk, motioning with his head for me to bend closer so I could hear. I was flooded with a feeling of gratitude, almost love. At last, I was going to hear from this strange man. Then, as I bent closer, he suddenly opened his large jaws and lunged toward me as if to bite my throat. It totally freaked me out. I jumped back and ran for the door, as if he could leap off the bed and attack me. When I was safely out and looked back through the little window, he was laughing. I waited till almost morning before going back. As soon as I came in, he said, "I thought you were the nurse," as if that would make it better. I said, "Just follow the light. So when the day shift comes in, they'll take you down to X-ray and get skull films." I should have spent some time with him now that he was talking, but I'd had enough of the vampire man. Another day, we had a new patient in the locked room. She was 33, so thin and frail you could almost see her bones. She'd been picked up by the police, who found her walking at the edge of the freeway, trying to get across. She told the cops that something was chasing her and that she was a marathon runner. In the locked room, she was pacing in tight circles. She looked so frail and harmless that I forgot to have her sit on the bed before I came in. But as I opened the door and came in, she turned to some invisible person next to her and cried, "Run for your life!" Before I knew it, she had sped out the door, past the nurse's station, and out into the parking lot. I was horrified. El Camino was just a few blocks away, 4 lanes of fast traffic, and I pictured her running in front of cars, trying to get away from what was chasing her. She'd get hit by a ca- if she'd get hit by a car, and I would never forgive myself. I didn't think. I dashed out the door and across the parking lot, calling for backup as I ran by the nurse's station. We ran for 6 or 7 blocks till we came to a large RV parked on the street. She disappeared behind it, and I circled back to face her at a distance. We were both badly out of breath. "Tell me about these people who were chasing you," I gasped. She looked at me as if I was crazy, but she didn't run. After a bit, the security officer from the hospital drove up and collected us. The next day, I heard that the whole hospital was talking about what I'd done. Apparently, you just don't do that. But she must have forgiven me for that chase because I became her doctor on 2N, the psych ward upstairs. She told me she saw creepy eyes staring at her from outside her window at night. She continued to be terrified, shaken. I learned that she was a hairdresser, working for herself for the last 5 years. We had no medical record on her. It was an odd history. When I presented her in rounds, everybody said the same thing: visual hallucinations, paranoid delusions. She's not schizophrenic. She has amphetamine psychosis. After 3 days, she was still terrified. I told her that her 3-day hold was expiring, but I hoped she would stay for a little longer till she was better. She agreed. The next day, she was different, no longer frightened. The creepy eyes were gone. Then she told me about the Ritalin. I'm supposed to take it every day, but I save it up and have a party. No sleep for days. She laughed, then caught my eye and paused. Maybe I should throw it out. That would be a good idea, I said. She left that afternoon, and we never saw her again. But others we saw over and over. They came into the ER, and their fat charts came up from the medical records, detailing their long history of hospitalizations. Most of them were diagnosed with schizophrenia. One day I was working in the ER when one of those fat charts came up. I opened it up to see the name, and the name was Jeff Bryant. That was the same name as a boy at my grade school, a year ahead of me. Everybody loved him. He was a star athlete, and when they were playing kickball and he was up, I'd stop to watch. He'd kick the ball way out over the field and lope gracefully around the bases. If he caught my eye, he'd give me the same "aw shucks" smile. But now here was a young man with a long history of schizophrenia, a repeat patient in our hospital. I hoped desperately that it wasn't the same Jeff Bryant. So I walked quietly out to the waiting room and I saw him, older now, but the same Jeff Bryant. I prayed that he wouldn't remember me. Fortunately, he didn't. He lived at home with his parents, never left home, Never worked. He came in over and over after stopping his meds and starting to act weird. I'd see him and go out to say I'd be with him in a little bit, and he always got this look on his face as if he had a deep secret, but he was about to show me. Then he pulled from his pocket a much folded and sort of dog-eared picture of a motorcycle with each part labeled tires, gear shift, handlebars. He was building it, he'd tell me. He showed me the same picture each time there in front of the nurse's station. There are many who believe that schizophrenia is caused by bad mothering, the refrigerator mother, they say, but evidence says the opposite. This illness is a brain disease. On brain scans, you can see changes in the gray matter. Jeff Bryant is a good example of the radical change people go through as they get sick. He went from being a very successful teenager to a completely disabled young adult. The last patient I remember from Ward 2N was Robbie. It wasn't Ward 2N. Yeah, his patients brought him in. He was psychotic, delusional, and wouldn't come in the house, wouldn't eat the food they brought to him. Instead, he was eating out of garbage cans. The other interns and I argued strenuously to keep him, but we were overruled. He had food, we were told. He found it in garbage cans. He had shelter, the garage. He had clothes. He was discharged the next day. It was a harbinger of things to come. After I finished my residency, I did a 2-year fellowship at the VA to get training in substance abuse treatment and to give us some badly needed money. After that, I went to work at Highland Hospital, thinking it would be like Gentle Chope Hospital, where I'd done my internship. But it was a rude awakening. We had so few psych beds that our patients were sent out almost as soon as they came in. I was shocked. We sent them back out to sleep on the ground. We actually wrote DC'd to Hobo Park in our discharge notes. When I started at Highland, I had a patient, an old woman, who was about to be discharged to Hobo Park after her one day on the ward. I was horrified, felt terrible having to tell her this, but she leaned forward and patted me on the knee. "It's all right," she said. "I have my own cardboard box. It'll be there for me when I go back." As the number of psych hospitals went down, the number of mentally ill people the number of mentally ill people living homeless or in prison went up. Today, a quarter of our homeless population and a fifth of our prison population suffer from severe mental illness, mostly schizophrenia. Working at Highland was depressing. When we took our coffee breaks, we never talked about our work. We couldn't bear to think about what we were doing. It was the first time I'd ever worked in a medical setting where we never talked about our patients. I stayed for 1 year, just long enough to get the money to buy a car, a small, inexpensive car. But I had some interesting patients there. Jack, a young man in the midst of a manic episode, was hospitalized after he'd written a letter to his girlfriend saying he was going to kill her, cut her body into pieces, and hang the pieces in the trees along the beach. She showed the letter to her parents. I assumed that we would discharge Jack the next day as soon as he denied his intentions. Instead, I got a visit from the chief of psychiatry. It turned out that the girlfriend's parents had powerful influence in the community. I was to put Jack on a 14-day cert as soon as his 3-day hold expired. Jack challenged the 14-day cert, and we had a jury trial. The DA asked me, "Why are you holding this young man? He looks perfectly harmless." Jack did look perfect, well dressed, his long hair neatly brushed back. I looked over at the jury. "He's on lithium," I said. It's like an umbrella in a rainstorm. It keeps you dry till the rain stops." The jury decided the hold was justified, and Jack went off to spend a couple of months at Napa. There was a piano there, and he took full advantage of it. In his normal life, when he was well, he had a band, but as he got more out of control, his band had kicked him out. "They replaced me with a meat hack," he told me. When he got out of Napa, he broke up with his girlfriend over the phone. Then he went back to his band and got his old place back. My favorite patient at Highland was John, a young Hmong man, severely depressed. His uncle came to see me on the ward. The family was having a healing ceremony for John, he told me. Could I release him for the ceremony? It felt terrible to refuse. John obviously needed the healing ceremony, but if I did that, he'd never get his place back on the ward, and he was still very sick. That's okay, the uncle said. We can use his jacket. So he went off with John's jacket, and they did the ceremony. I think it was helpful to John, who was well enough to go home after a week. The antidepressant helped, but knowing that his large, loving family was waiting for him clearly helped. So, why do we put people with serious mental illness in the hospital for treatment? This is the reason. In the hospital, we see our patients every day, sit down with them, hear from them. If we put them on medications, we can see day by day how they're doing, hoping for improvement with minimal side effects. We can adjust the medications if needed. Also, we're not the only ones seeing them. The nurses, with their long experience, see them and tell us what they're seeing. Other doctors and psych techs do the same. In addition, many people with serious mental illness, especially schizophrenia, suffer from anosognosia, the inability to understand that they're sick. This makes outpatient care an even more iffy proposition. Will the patient show up? Be there when we go to see them? Agree to be seen? Go to the pharmacy to pick up new prescriptions? Take the meds at all? In many cases, the only way we can treat serious mental illness is in the hospital. And it's easy to see why, after losing almost all our psych hospitals, those people would end up homeless or in jail. Since 1965, should I pause for a minute? Okay. Since 1965, we've lost 90% of our psych hospitals. There are several reasons why we've lost so many psych hospitals. One is the IMD exclusion, also known as the 16-bed rule. This is a rule created by Congress in 1965, along with the new medical benefit called Medicaid. They were afraid that the huge psych hospitals would gobble up this new benefit. Now, any hospital with an IMD unit, Institute for Mental Disease, of more than 16 beds would lose funding for that service. As it happened, Thorazine had just appeared on the market, the first antipsychotic drug. Why would we need these hospitals when we had Thorazine? Other voices joined the chorus. Thomas Szasz published The Myth of Mental Illness. Ken Kesey wrote One Flew Over the Cuckoo's Nest, which was made into the movie we've probably all seen. Kesey had written the book while he was a student in the Stanford Writers Program. At the time, he also was a paid subject in a study of LSD. Every Tuesday, he'd get his dose and then spend his days sitting in a little room off the psych ward of the Menlo Park VA, looking out at the goings on. At night, he was a nursing assistant on the same ward. Kesey was careful in the book to show that Chief Bronson was an unreliable narrator. Chief tells the reader about how Nurse Ratched swells to an enormous size, smells like a tractor straining under a heavy load, and how her arms elongate to reach across the ward and clutch the luckless boys. In the movie version, none of these clues are present. The ECT teen is terrifying. It takes 6 strong men to hold down the poor patient as the electric shock jolts him and he thrashes in agony. The city of Berkeley outlawed ECT. I remember when I first saw ECT in real life in med school. I was horrified at what I'd see, terrified for my patient. I brought him to the little ECT station, just an alcove off the main room. There was a doctor and a nurse and a bed. The nurse tied a tight cord around one of his big toes. Then she started the IV. In the IV were a sedative and a muscle relaxant, so he'd be asleep, and if he thrashed around, it will only show in his big toe. So the big toe with the cord tied around it prevented the muscle relaxant from affecting that toe. The doctor turned the dial on the little black box and watched the patient's big toe. When it moved, that signaled a general seizure, and he turned back the dial. That was it. The patient woke up, and when he was ready, I took him back to his bed, which was my actual job. After the seizure, his memory for everything in the past day or two, like how to get back to his bed, was wiped out. but most of us don't get to see ECT as it's really done. So I'm wondering if anyone has questions or if I should stop here.
Can I
Yes,
question?
yeah.
So, I have a young friend who has schizophrenia who's doing remarkably well on medication. But his father, who was a hospital pharmacist, was explaining to me about abnormal synaptic pruning and the relationship between that. And I'm just wondering if anybody's working on a way to um, chemically interfere with that so that they could actually have, catch it early and have a cure for
Mhm.
schizophrenia.
And that would be wonderful. I haven't, I'm sure people are, but I don't know anything about it. So,
A
right.
couple of things. I'll talk just generally about schizophrenia. And then on a side note, my wife used EMDR and so on, and there are some theories which deals with trauma and abuse that some of schizophrenia is triggered by some kind of traumatic event when the kids are like young adults, and kind of I talk about that.
Well, triggering the first episode often happens, with some um, difficult or even traumatic event. Very commonly, people have their first break when they go off to college and leave home and are suddenly, surrounded with all these new things to deal with. But reliable studies show that schizophrenia is hereditary and not caused by, you know, the refrigerator mother or whatever. And what was your other question?
Oh, I was just going to say, my friend that I was just speaking of had three sons. Two of them had schizophrenia. The middle
Yeah,
one was totally untouched.
right.
The first one just never felt helped by medication and ended up hanging himself.
Mm.
Well,
The the youngest one um, had this, and I think there were things in your book about sometimes um, pot use and other drug use can be a part of the problem. And I think it was a combination of all the things you talked about. I think he had broken up with a girlfriend. He was staying up all night smoking pot and playing violent video games and stuff like that. And he started hearing voices. And
mm,
then he went for a walk and he was protecting himself because he felt quite paranoid. And he saw a neighbor hanging Christmas tree lights and he attacked her with a knife because it was during the Mayan calendar scare. And he thought the world was ending and she was signaling to aliens that were attacking. Now,
wow.
I know all this. I met this kid when he was at Napa State and watched him go through all these developments. And I just want to say, I consider it a major miracle that he goes to the Safeway pharmacy and gets a shot every 3 months. And he has a girlfriend, and he did online training to be a vet assistant, and he's really he's not the same as maybe a similar guy his age. He did have a traumatic upbringing with an abusive mother.
Mm,
So, there are all these things that play into it, but just to see him doing the difference between him now and when I met him 10 years ago is astonishing. So I sort of wish when I see all these people wandering the streets, gesticulating wildly and doing all this stuff, I have mixed feelings about getting people involuntarily into treatment programs just because it was such a miracle for him.
yeah. Yeah, well, that's as good as it gets. I mean, people do, especially if you jump in early at the very, very beginning and give the right treatment, which is I'll talk about it. But yeah, uh, some people head it off at the beginning and then they stay on meds, which is, what they need to do. But they manage to go off and have a good life. which is wonderful. I think we should do that, oh, everyone, for everyone. Brian,
Yeah, I haven't read your book, so uh,
okay.
I may not know where the story's going, but you told us these interesting anecdotes, and in most cases, you didn't tell us how you felt about it and how you felt about the institutions, whether these were, in fact, places of healing or not. Is that where you're going in the talk, or can you talk a little bit now about the threats of the guy lunging for your neck and things like that?
Yeah. Well, in that case, I was scared and then, really angry. But, but, you know, feel different with different experiences. Sometimes, a lot of times, I just feel really sad for a patient, if they're really disabled. Sometimes I feel confused, but mostly, you know, they're a person suffering a lot.
Well, I just wanted to talk more about Alice. You said that it's hereditary, but I have a feeling that there's many factors involved. I have to deal with a schizophrenic stepdaughter for many years. I know I've talked about her, and she was raped when she was 14 and had to have an abortion, and her parents broke up when she was only 2, and she really led a traumatic life for a lot of reasons, and um, so I think that all those things contributed to it because neither her mother nor her father nor anyone else in her family had schizophrenia, and she ended up on my doorstep after leaving San Francisco or Reno and was totally out of it. And it took, she was with me for 5 years and finally was well enough to move back to Denver and have a roommate. And now she has a place of her own and she would go on and off meds. And we have a 3-day holding like you do in California, here in Colorado. And it's really awful, though. Our medical district is with Grand Junction, which is 5.5 hours away, whereas Denver is an hour and a half away. And yet, when she took a gun and went to a motel in Winter Park and was going to kill some people she thought were there, I called the cops and they picked her up. And I mean, she's so resourceful, though. She went to the bathroom and emptied the bullets out of her gun, and so she got away with it. Except they handcuffed and ankle cuffed her, put her in the back of a police car, and drove her all the way to Grand Junction, where she spent 3 days. And every time they get her on meds, she'd go off meds. I mean, it's a real conundrum. There's so many things going on there.
Yeah.
She's
Yeah.
fine. She's doing quite well now. Has an apartment of her own and gets a job, can only take it for so long. Then she goes on unemployment and then she gets a job. and but she's surviving.
Yeah. Oh, that's good.
If I can jump in, because Ron, it was a perfect question. I didn't think you really answered it about, how you feel about the institutions that you, as I understood the question, are they helping or are they not? And I thought, but well, maybe you're going to talk about this more, but the difference between how you felt at CHOPE, where they were taking, and you talked about the patients and you helped them, and there was a hope for recovery. And then your later work, where, like you said, at Highland, where they didn't even, you had never talked about the patients, and um, and then your later work, which you haven't really talked about, where
Yeah.
it was clear, to me at least, that yeah, that's the point, that the way things were handled, they were being helped, and there was hope, and there was the possibility of recovery. Whereas in the later institutions, no, and they're not helping,
Yeah.
and so forth.
Yeah. Very frustrating. Should I go on? Okay. Uh, let's see. we go. Okay. Um, so next I'll talk about a foray into addiction. When I was in college, I lived at Barrington Hall, where I was a switchboard manager. Part of my job was to cart off the old stale cigarettes from the cigarette machine right next to the switchboard after they were replaced with fresh stock. I thought that in my future life as a social worker, I'd be caring for heroin addicts, so I should experience addiction for myself. Also, I wanted to lose 10 pounds. My plan was to smoke up all those old stale cigarettes, and when that was done, I'd quit. 5 years later,
Huh.
in med, I was in med school in Pittsburgh, still trying to quit. We had a little coffee stand with chairs and ashtrays, of course. It was just us med students, except for one faculty member, Melanie Graves. She was a pathologist and would be teaching us next year. I was dreading that year, looking at lungs full of cancer and unable to quit smoking. One day, I pulled up a chair to her little table and joined Dr. Graves. I asked her how she could keep smoking, seeing what she did. She looked incredibly sad. I'm always trying to quit, she said. Then I get a call from surgery. They have a woman with a probable breast cancer. They put the operation on hold while I look at the slides. I lit a cigarette, first thing. If Melanie Graves couldn't quit with all that she saw, what chance was there for me? Then, out of the blue, my mother wrote to say that she was paying for a week at our grandparents' cottage at the lake for me and my sister Helen. The first thing I saw when we got there was a cigarette, barely smoked, lying in the big glass ashtray on the card table in the living room. I could tear off the filter for safety and smoke the rest. I could have thrown it away, but instead I put it on a high shelf off the kitchen, just in case. We spent that week reading, playing cards, and sailing. We saw just enough of the aunts and uncles and cousins to be properly sociable. I ate 21 meals at the dining hall and drank coffee every day without a cigarette. At the end of that week, I took the big glass ashtray from the high shelf, tossed the disgusting old cigarette in the trash, wiped out the ashtray, and put it back on the table. It's probably obvious, but it's useful to have a safe place to go for a couple weeks with no pressure to perform when you're trying to quit your drug of choice. Melanie Graves did not come back to our pathology, to be our pathology prof. I never saw her again. In the 1980s, Oakland was swamped with crack cocaine. I took a job at Kaiser Oakland with a mission to revamp the drug and alcohol service. I worked with 2 nurse practitioners, and we overhauled the treatment program. We stopped writing prescriptions for benzodiazepines like Valium or Librium and turned to group therapy. We started support groups, AA, ACA, OA, and cocaine groups. We dropped in on local AA groups to see which ones we could recommend for our patients. It wasn't like the movies. No one was put on the spot or even asked to speak. If there was a check your weapons at the door feel to those groups. And we got the Kaiser administration to give us a space for a new AA group on the premises. I went upstairs to see the space for the new group and talked to the rather grouchy worker who had to take on this new task. I told him what it was for, and he turned to me with a big smile. I'm in the program, he said. Anything you need, just ask. We treated addiction to alcohol, heroin, and cocaine. The people who suffered the most were the cocaine users who smoked crack or freebase. Crack cocaine and freebase are chemically altered, allowing them to go straight into the brain. That creates an intense high that fades quickly, leaving a desperate hunger for more. People who never had any kind of trouble with alcohol or drugs found themselves digging under the couch cushions, desperate to find the last crumb. Money flew out of their bank accounts. Wives or husbands kicked them out, and they moved in with their mothers. The last thing to go was their jobs, which were vital. They needed money to support their habit. We had nothing to give them to help them through those weeks of cocaine withdrawal. It was brutal. However, the commonest drug problem was alcohol. Human beings have lived with alcohol forever, As with schizophrenia, it was assumed that poor parenting led to alcohol abuse. But studies here and in Denmark showed that heredity is the key. What can you inherit that makes you more likely to drink too much? It turns out that we have a metabolic pathway just for getting rid of alcohol through a dedicated set of liver enzymes. Those with a powerful set of these enzymes were at most for risking of developing an addiction. So now I'm going to talk about treating psychosis in private practice.
Alice, I just like to interject something about schizophrenics and tobacco smoking.
Right.
My stepdaughter has smoked all her life. Her father did too, and she's never been able to quit. And a lot of schizophrenics apparently are addicted to tobacco. And I just looked it up. It said 88% of schizophrenics smoke cigarettes, whereas that's 4 times the normal population.
Yeah.
Do you know, have experience with that?
Um, I never really thought about it particularly, but yeah, that makes total sense. Um, you, well, I would smoke when I was anxious. And if you're anxious all the
Yeah.
time. So, yeah.
Also, you didn't, just as an interruption, you didn't mention, I don't think, although I thought it was in your script, that the reason that the Dr. Groves, was it?
Dr. Graves, yeah,
Graves, the reason she didn't come back was because she
she
died
died.
of lung cancer.
Yeah, right. Yes. I, I went right by that, I guess.
I wondered about that.
Alice, I wanted, it seems to me like a lot of people that I know that have various addictions. I mean, it's not always something like smoking or alcohol. Sometimes it's just behavioral addictions, like real excessive exercise or things like that. It seems like they're sort of self-medicating with an underlying psychiatric situation. Do you think that is likely?
Yeah, partly. I mean, like I think of a patient who was smoking and appeared to have schizophrenia, but when she stopped smoking, those symptoms went away. So I don't know. But I don't know if I really answered your question. Okay. Shall we go on? Okay. So I'm going to talk a bit about treating psychosis in private practice. I had opened a new office in Walnut Creek, a lovely space looking out into the branches of a live oak tree. I planned to be there for a long time. I got a new referral, Amy. I was warned that she was pretty disturbed. I didn't worry. I'd seen so many people who were very disturbed. Her complaint was about Linda, a childhood friend who wouldn't let her have babies. How does she do that? I asked. By having babies, of course, she told me. I'm going to kill her and all her kids. Suddenly I remembered what I'd been told. She's pretty disturbed. I'm sorry, but I'm required to warn Linda if you're serious. I'm totally serious. How would you do this? I asked her. With a gun. She didn't have a gun, but she told me how easy it was to get a gun, and I knew that. I tried to reach Linda to warn her, but she had vanished. I called the state agency that keeps track of people who shouldn't have a gun, and they'd already been warned about Amy. The next time we met, Amy said, I'm going to force you to have lunch with me. Then she told me about a dream she'd had about Linda. In the dream, she threw her purse at Linda. Then Linda turned into me. Amy smiled calmly at me, picked up her purse, and heaved it at me across the room. I can't see you anymore, I told her. You're scaring me. You're talking about murder. I never saw her again, but I was afraid for a long time. I gave up my office in Walnut Creek, where I'd begun to feel like a sitting duck. But my real worry was for my 2 small children. We're easy to find. Amy could go to my house and wait for my kids to come out the front door. She could get a gun, no problem. Okay, now I'm going to talk a little bit about schizophrenia. Schizophrenia is our most serious mental illness. It affects about 1 out of every 100 people on Earth. Unlike other mental illnesses, it must be addressed immediately with the first psychotic episode or even sooner. The treatment must be provided by a team of clinicians, a therapist, a psychiatrist, a family therapist, and a voc rehab counselor. The treatment is ongoing for a couple of years. Unfortunately, we do very few of such early interventions. As a result, people with untreated schizophrenia end up living on the street, a quarter, and behind bars, a fifth. Listening, unconscious communication of emotional states. Freud talked about this. They need to have a sort of roving awareness, not only, sorry, not only of the patient, but of yourself. That is, your own emotional state. One of my first teachers, Dr. Poe at Chope Hospital, told me, if you find yourself feeling angry when you listen to someone and you can't figure out why, there's a good chance that they're angry. The idea is that emotional states sort of osmose from one person to another without our awareness. We need this facility because we're social creatures. Sensing others' emotional states is important. It's the music, not the words. It won't be in the conversation necessarily, but in tone of voice, posture, facial expressions, body language. Dogs, who are social animals, have a version of this, but cats, who are loners, don't. We pick up right away what's not said, but is crucial. It could be terror, anger, grief, disgust, lying, hiding. People with schizophrenia lose this ability. Grotstein, an analyst who treated schizophrenics, writes that schizophrenia is primarily a disorder of meaninglessness. All that we take for granted to make sense of the world is gone. This is a long introduction to Chris, a young man with early schizophrenia. He was brought by his mother, who was determined to get him psychiatric help ASAP. When I met Chris when he was 22, back from college after being hospitalized for a psychotic episode. I was the fourth psychiatrist he's seen, one in Texas at his school, and two here. His mother brought him to see me. Chris was rail thin. He was tall with a stoop that gave him a hangdog look. He was pale with freckles and thinning red hair. He stared at the floor in my office for a long time. When I asked him, he said he was doing fine. There's nothing wrong with me. I can take care of myself. I nodded, wondering why I'd agreed to see him. He paused for a long time, then said, there was a test to see what sort of human being I was. I failed. It was a joke prank. I had a freak out in chemistry. They talk about my inadequate performance. I was starting to get that fuzzy feeling I get when I'm struggling to follow the logic of someone with a thought disorder. It feels like my mind is slipping, as if this disordered thinking is contagious, and it is. Chris wasn't making sense. Is there a question? We stop? Okay. Chris wasn't making sense, but he brought me along with him into his emotional state. Sad, I realized that he was in the early stage of schizophrenia. After he left, I read the medical records we had and called the previous psychiatrist. Last of all, I called the pastor in Texas who'd seen him for pastoral care. He told me about Chris's miserable history. At the end, he felt broken and unfixable, he told me. Those last words conveyed so much pain and hopelessness that finally I couldn't walk away. For better or worse, I was all in on Chris. I saw him for the better part of 4 years. The psychosis gradually receded. After we'd been meeting for several weeks, he glanced quickly at me and then sat with his eyes fixed on a small Chinese cabinet a few feet away. I can't decide if this whole thing, the voices, has been hallucinations. I wanted to leap up and cheer, shouting yes, but I restrained myself. I said, I think you're right. We continued to meet when he was home. He traveled, experimented with being on his own again. He was hospitalized once more briefly. He was a wilderness guide with a troop of teenagers, and that went well. It's important for me to feel respected, he told me. He took an advanced math course and aced the final. I think I could live at a higher level, he said. 4 years after we first met, he resettled in the East Coast as a graduate student in math. Several things are worth noting about Chris's history. First, his mother was involved from the beginning, stepping back when appropriate. She found him easy part-time jobs when he was ready and communicated with me in the beginning. And I saw Chris in therapy as well as for medications. And most important, we started at the beginning of his illness. This is what it takes to successfully treat schizophrenia. So now I'm going to talk about treating psychosis in private practice. I had opened up a new office in Walnut Creek, a lovely space looking out into the branches of a live oak tree. I
Or
planned,
you already you did this.
oh, sorry. Oh my God. Yes, you're right. Oh my God. Sorry about that. Okay,
Lois, can I ask you about that incident? You
sure.
suggested to us that this one patient who talked about having a gun and threatened you drove you out of private practice. And I just wondered whether that was really enough or whether there was something more that made you decide that wasn't the right path.
Uh, there's always something more, but she,
But it didn't drive you out of private practice. It just drove you out of that office.
yeah, right. That's
She
right.
just changed her office. She didn't leave private practice because
Oh,
of,
thank you. I misunderstood. I thought
Yeah.
she changed her career path.
no. She got an office right across the street from our house.
Oh, that's helpful. Especially when they can figure out where you live. I had
Yeah.
a similar experience with a patient who was going to kill my children.
Um,
And it is, it's very, very unnerving. Where you go from there, you know.
What kind of a patient was that, Julia?
Well, I worked for Milwaukee County Mental Health and for the first 4 years, and she was an outpatient. No, actually, I was in private practice with her. I remember that because, yeah, we had the kids. I was in private practice, and I just kept working with her, trying to get her to a different therapist, basically. And, we talked about how, something that it was hard for her to work with me, and she needed to be, look at some other options, a psychiatrist, somebody that could be more helpful with some of these thoughts that she was having.
Was she schizophrenic?
Yeah, I think she was. She was not, I was in private practice and I had a practice that was working with women and families who were coping with infertility. And she had found out that I had children. And I don't know. So there were a lot of issues back and forth with people that I worked with that were not as stable as others, around that. Um, but she did get to somebody else, but it was a scary time.
Anything else? So we don't have very long. We have about 5 minutes. We could pause here and go on next time, or go on with the whole thing for 5 minutes.
Well, you were lucky with one of your patients. I had a patient who did kill somebody, and I was at that point I was at Milwaukee County, and I was at an outpatient clinic, and he was coming to see the psychiatrist for medications and counsel talking with me. It was in the days when they had Johnson's money, and they had a lot of catchment area availability in communities, and it was kind of a golden time in many ways. Um, I thought, compared to what has happened.
Um, anyway, but he had had a breakdown at Notre Dame and came in. His mom brought him in after he was released from the hospital, and he would see the psychiatrist and me, and then he didn't show up, and he went off his meds, and I, followed up too late. It was like he missed an appointment, and I called the first of the week, and they couldn't find him, and then they found him, but he had committed a murder.
Oh, no.
Yeah,
Well, preview of things to come. Alice had a patient who committed a murder,
yeah.
or at least a homicide, but that comes up. That comes up in the next part.
Yeah.
Alice?
It's a
Oh,
very different situation.
Yeah, very.
yeah.
So, Alice, I wanted to say I've been reading your book. Ta-da. And I find it really, really helpful where you explained about what happened to mental health care in America and why it happened and what happened to make so many people homeless now when they weren't homeless before.
Right.
They were nice, clear, and straightforward explanations of things that I sort of knew but hadn't put together. So are you going to be talking about that as well? Because I thought that was a really
Yes,
helpful.
absolutely. I mean, mental health care has changed radically. I'm going to go into that, obviously.
I get the feeling it doesn't even exist anymore.
Well, if you're not too sick, if you can do with just therapy, that's okay. You're doing okay. But, for serious mental illness, it's really, really
Yeah.
hard, especially if you don't have a lot of money. Uh, yeah.
I'm curious what you would say about your your fellow doctors. I mean, you seem to have a remarkable level of equanimity and calmness. But the one or two psychiatrists I know are wild people. I mean, they're quite opposite. And I wonder, in the teams you worked on, were there more Alice's or were you the odd one out?
Well, what do you mean by wild people?
They reminded me of junior high school teachers, adolescents who had highs and lows and didn't see things as middle ground, but had intense feelings about things and expressed were outward in their expression.
Wow. Well, I thought we were a pretty mild bunch, but I may have just imagined that. I don't know.
I think, Alice, I remember you're saying in your book that you had intentionally, when you were choosing people to be trained by, you had intentionally chosen people that tended to be relaxed and, didn't take a very tight approach to medicine and stuff. I thought that was a good decision.
Yeah,
Can I ask one other quick question about schizophrenia?
yeah.
Um, so in the book, oh now, where did it go? Okay. You mentioned something about hmm. Okay, that train of thought just derailed while I was
Just come around again.
it's going to come back in a second, but I had another question about it, about the treatment. It will come back, I'll tell you. Okay.
Well, Alice, I have a question.
Yeah.
When I read your book, it was very clear that our approach here in the United States or in California is not working very well for these people. So one question I have is, are there other countries or other places that are doing a better job with this? And if so, what are they doing that's allowing them to do a better job?
Mhm. Well, yeah, that's absolutely true. You go to, like, we were in South America and I kept looking for the homeless people. Where are the homeless people, I mean, everybody has them, don't they? But I think that we do very badly compared with other countries. One of them is that we don't have a single payer. We have everything is fee for service. And I'll go into how that really distorts our work and our writing particularly. It just, and we have 90% of our beds are psych hospital beds. So people go to jail or they go to the street.
Alice, you reminded me of my question.
Okay.
So this might be something you'll be discussing later, but you mentioned that because of the fee for service, sometimes people feeling that they're not getting paid enough by the time the insurance, whittles down what the amount they're paying, that they would sort of upgrade the diagnosis for the person, often to schizophrenia. And then they were locked into that diagnosis and they were being treated for schizophrenia when they didn't actually have it.
Yes.
And it was very hard to get off that wagon. And I'm curious about this because I do sometimes wonder about my friend's son, So that's a really good argument in itself for single payer to not have people treated for diseases they don't have.
Absolutely. Yeah, absolutely. Yeah. Upcoding.
Yeah.
I don't know if you were going to tell the story, but that's a major. Can I tell one story? When Alice got word that that a publisher wanted to publish her book, we were on a trip in London, and we were all excited, so we were people around us that she's got a publishing, and there was a guy who was a hospital administrator. He was a doctor, but he'd had a career as a hospital administrator. And I sort of described for him this upcoding, which is exactly what you were talking about. And I think Alice is going to talk about it more about everybody being. It's not even the doctors who are diagnosing schizophrenia. It's the intake workers, and they put that down, and you're stuck with that. It's in the medical records, in the electronic medical records, and it can't be changed. And so you have all these people with diagnosed with schizophrenia because that's the highest compensation. And when I was telling this hospital administrator on this trip about this upcoding, he said, "Oh, yeah, I know all about that, but we have a simpler word for it. We call it fraud." And, and that's exactly what it is.
Yeah, absolutely. Yeah. Hi. Okay.
Yeah, that's a thin line.
Thin line. Okay, well, are there any more thoughts or questions or comments? Okay. So I'll see you guys next Tuesday.
Thanks, Alice.
Not me.
Thanks, Alice.
Thank you. Thank you very
Oh.
much.
Thank you, Alice. It's
Right, yeah.
wonderful
Thank
information.
you. Yeah, we
Okay.
got a lot to learn.
Yeah.